It's my AV guy. I guess I gotta hold it in my hand. Yeah, it's fine. I just want to thank you guys for coming out tonight, and I want to thank our president, Dr. Stalick, for doing such a great job this year and inviting me to come and speak to you guys tonight. So I have at least I consider a fun evening, power pack. We got a lot of Q&A, and I like to kind of do some dialogue. So you guys that's sitting way in the back, don't worry. I'm going to come back there and ask you guys some questions as well. So before I get started, I wanted to show a little quick video about myself and also my office, and hopefully it'll also be a little entertaining as well. So I'm going to see if this is going to work here. And I'm a new guy to Mac, so I'm a recent convert from the PC. So you guys just kind of bear with me a little bit. You got any Mac guys in here? Any good Mac guys in here? Got a few? Patel? Got a few? Okay. All right. So.
Anybody's ever had a toothache, it's the worst pain, and mine had blew up, and my whole face had blew up too. So it was like the tooth had taken over my whole body, and you know that pain right there caused a whole pain in my whole face, whole body ache, throbbing. This is the worst pain ever, man. Please, somebody save me. And to the rescue, Dr. Short came.
I just want to be able to do the best I can and be the best at what I do.
I always hear about pain. I didn't even have any pain dealing with Dr. Short.
My concerns about getting a root canal before Thanksgiving was that I would not be able to enjoy my dinner that we'd had planned for the whole family, but that was no problem whatsoever.
Function through it. I've never really been apprehensive about local anesthetics. I've given it up myself, but I was comfortable during the procedure.
Basically, it boils down to the golden rule. You treat people how you want to be treated. And me, as being a patient, I would want to be well informed on what I'm getting and why I'm getting it. Some of the people that came through the office, entertainers, artists, comedians, choreographers, to be able to take care of them in a painless way is critical, because these guys are on national TV. They are doing huge concerts. So the last thing they need is a tooth problem that can prevent them from being able to perform.
I go to this doctor, and I'm thinking that, you know, he's really going to help me. He looks at my tooth, and he says, man, you need to just pull the tooth. I say, you know what? I don't really want to pull my tooth. So I got in my car immediately and left this dentist, and I went to Doc, to his office. And I went in, and he looked at my tooth, and he was like, man, you don't need to pull your tooth, man. You're good. You know what I'm saying? I can fix this. And, you know, I was like, for real? Because everybody else had told me I needed to pull the tooth. And he told me, man, I got you, man, for real. He showed me, he printed it out. He had the screen, he had the flat screens and all the stuff. He showed me what was wrong with my tooth. And he fixed it. He just did some things that, you know, the other doctors couldn't do.
The experience I had at Dr. Short's office, just from walking in the door, his office was very inviting, very comfortable and relaxing, and whenever I was in the chair, he just made me feel very comfortable. You can tell he's passionate about his work. Me being able to watch TV was a plus, always, and yeah, just the whole time I just felt relaxed.
Our relationship to the general dentist is basically an extension to make sure their patients are receiving the optimum level of dental care.
He actually practiced general dentistry coming out. So the ability to have a specialist that understands the role of the general dentist, I think that helps in the way you treat patients. They see things from a general dentist perspective. There are times when we've worked on cases together and he's mentioned, well, you might want to check this, or you might want to do this. From a general dentist perspective, not from an endodontic perspective, that's helped me become like a better dentist. the way we practice now, the patients are getting a much better dental experience than, say, one person trying to do everything. You can't be perfect at it all.
Technically and skillfully is very good at what he does. He even, with the general dentist, he'll send us emails of radiographs not attached to a patient's name, but just say, what do you think's going on here? Or look what we were able to accomplish. And it's just like some of the most complex things you've ever seen that really without, the great equipment that he has and the skill that he has, it's just not possible to do.
The operating microscope to the surgeon has been a tremendous advance for the reasons I've said, that you operate in a smaller field, less trauma to the tissue, oftentimes a quicker procedure, and this is one of the things he does.
What I liked best, I think, was that when he finished the case, he followed up on it, and if the patient had any sort of discomforts or any minor things, he would follow up on it until they were completely satisfied.
On average, when I actually come down to treat patients, we see anywhere between 8 to 10 patients, and each patient may need anywhere from 1, 2 to 4 teeth extracted at one time. There are some days that I actually teach the dental students, and it's actually a full day that we actually teach them, but it's always rewarding. All right, get ready for war here. Good war, that is. We're fighting the war of tooth decay. Let's go and see what we got. The issue is
Experience is something that money can't buy. Just the experience to be able to touch someone who's been hurting and they can't afford any treatment, and to be able to turn their life around in a matter of hours by taking care of something that's been hurting them. It's phenomenal.
You got it. Thank you.
I just think he's made a real difference to our profession, as well as, to our community.
One who's inspiring through his works, teaching people not just only the field that what he's in, but just morals and just how to be a man.
I always recommend Dr. Short because I know that, he can get the job done. He really got in there and he really kind of did some things. Now I have a bionic tooth now. Thanks to Dr. Short. Bionic. So this tooth right here might got some wings on it. And it might take off and fly one day. Dr. Short did. So go see him.
So, that's just a little bit about my office, and no one was paid, so this wasn't a paid advertisement. They were just nice enough to just show their appreciation for the type of work that I do, and I think the type of work that we all should be doing as dentists, because we all are dentists, whether we are specialists or not. So, we're going to go ahead and get started tonight. I'm going to be talking about endodontic retreatment, and the title of it is Endodontic Retreatment Passé? The definition of passé, that means outdated, old. Is this something we need to still be talking about with the era of implants? And we know the success rates of implants. So we're going to be digging into some of that stuff tonight. And I do want to encourage everyone to ask questions. Please, no fighting, but ask questions. And we're going to have a good time tonight. I also have some goodies too that I'm actually going to be giving out too as well during the presentation. So let's just jump right in here. My office is Apex Endodontics. We believe the whole world have a root system and everybody should be endodontist. But anyway, we're right here in Smyrna, right here, God country where the sun is always shining. Is that right, Robert? See Robert's around? So, I have a mission statement. By show of hands, how many of you guys have mission statements? We got at least a few, okay? I think mission statements are very important because that describes the philosophy of your practice. That describes how no matter what kind of hell day you have, you stick to that mission statement, that gets you back centered. And my mission statement is we are committed to providing the most excellent service, technology, and treatment in the area of root canal therapy. By applying the principles of trust, respect, honesty, integrity, and commitment, we nurture an atmosphere of healing and comfort. Our goal is for each patient to be so satisfied with our service that they go out to the world and tell people about their positive experience here at our office. So no matter if I can't find that 4th canal, if I spend an hour trying to find 5 canals on a lower molar, and I'm very frustrated, and I want to quit, and I do have some endodontists that have had those days, just want to walk out, you know, and then you kind of go back to what is your mission statement. That kind of gets you back refocused. So I take a quote by Benjamin E. Mays, and every time I speak, whether I'm speaking about dentistry, whether I'm giving inspirational lectures or what have you, I really take this to heart. Is whatever you do, strive to do it so well that no man living and no man dead and no man yet to be born can do it any better. And that's what we want to strive. Not only me as endodontist, that's what you should strive to provide that type of service for your patient. I became a diplomate of American Board of Endodontics. This was one of the most challenging yet rewarding phases of my life. The reason why I did that, I wanted to achieve the highest level of knowledge and skill possible in endodontics. Also, I wanted to continue pursuing new techniques and applying new research in endodontics. I want to ensure the highest possible quality of care for my patients, as well, which is the most important, is sharing vital information to my friends and colleagues and even patients. And I know we were very concerned about this thing about what's going on. Do these public people know that what we do as dentists is good? Do they realize that we're getting a great service? But guess what? We have something called a social network system. Anybody have a Twitter account, a Facebook account? By show of hands? Okay. If you don't, I encourage it. These people read that stuff and they believe it. I've been on Twitter and Facebook now for probably about a year. You know, I've gotten not only patients, I've gotten special invites to special events that you would believe. And a lot of people just want to sit down and talk to me candidly about what is a dentist and what is a root canal, because root canals hurt. Where do you think they heard that from? Everybody's scared to answer that, huh? Lack of anesthesia. Lack of anesthesia. I heard internet. So, Kumar, the first guy. So I got something for you, man. I got you some hand sanitizer. And, no, I only got smalls. Sorry. Here you go. All right. So that's right. They, you know, lack of anesthesia. We hear other things. I heard somebody say internet. Who knows? I mean, a lot of people have had some bad experiences, but yet, do you know some people have had good experiences? Do you know some people have told me, which I'm pretty sure they've probably told some other colleagues that, wow, sorry, I'm getting some feedback here. So I became board certified in 2009 in San Diego. And in 2010, I've been very blessed to work on quite a bit of celebrities in Atlanta. And I don't know if you guys know this, but Atlanta is going to be the new Hollywood. There's a lot of movies getting filmed here everywhere. So I've been able to plug into that. And one of the systems I use is the social network system. And that just kind of buzzes out. And I'm able to develop a niche for that. So I'm able to see guys like this guy. Pretty sure you guys have probably seen him. And I haven't worked on this young man yet. I'm not sure if his apices are fully formed yet for me to do any root canals on him, but that's Usher and Justin Bieber, just in case you guys don't know. I've been fortunate to work on another guy that used to drive for NASCAR, and he's also an announcer, a guy named Calvin Fish, and he's told me all types of horror stories about root canals and all these other things, and we were able to change his mind, not only just root canals, but about dentistry in general. I'm pretty sure you guys probably seen this young lady's face as well. And the list can go on and on. I just kind of threw a few other people in that I was just very fortunate to be able to touch their lives. And they have the influence to touch many millions of people's lives. These guys are on TV. They have their own shows, a lot of things like that. And I'm actually helping dentistry from a different aspect and using my influence through them to get out to people like Sean Puffy Combs and P. Diddy and my other good friend, Fosworth Bentley, who had an hour show on MTV called G's the Gents that came on right after Hills. Now, if you guys have kids, teenagers, you guys may not know what the Hills is or was. Anybody know what the Hills, story Hills? Or, Okay, we got a few people shaking their head. Other people just embarrassed to raise their hand because they probably watched the show. So anyway, we treat everyone like a star. Everybody gets treated the same. So that makes us very unique in that we don't have a star room, we don't have a dressing room. We put everybody in the same room. Or if we get some celebrity that's really high strung, we will just block out a certain amount of time and just have them in there and also treat them. So we are blessed to be dentists, and we must give back. I did see a few videos and a few pictures going through. These are some of the organizations I'm affiliated with. BMSL, of course, is one. Good Samaritan Dental Clinic, the Cobb County CAP program for kids, Dentistry from the Heart, and also the GMOM. So by show of hands, can I see some of the guys that volunteer at some of these places? Hopefully that's everybody just about that should have raised their hand. That's great. But yet they say we don't give back. They say we don't give back to dentistry. But guess what? Do you have a video on your website showing that you give back to dentistry? Have you written a paper? Have you tweeted? Have you posted it? No, so how will they know? They won't. So what I do every time I go and speak to a group, I always take a little video or some film or some pictures and I post it. In fact, I actually wrote ABC News. I think, Wilkie, you sent me that that clip about the ABC News, and Diane Sawyer was talking about access to care and all of that. I sent them back probably about 4 or 5 of my YouTube videos of me giving back. You think they called me? No, because they know usually what? Bad news sell, good news usually don't, right? So, but if all of us collectively, because I know we give a lot of dentistry away, and if we just use the social network system, I mean, of course, use the ADA and all the other organizations, I can guarantee you, we will make an impact in that. So, I'm kind of old school. I've been at, by show of hands, who all been at the old BMSL clinic? All right, I call it the matchbox or the mini prison, the mini dental prison, right? So, from there to the new BMSL clinic is awesome. This is, I actually came down and I'm actually getting ready to start a microscope course. So those of you guys want to use the microscope, which I was gracious to get on loan from Global with Mike Austin. I'm going to start teaching some courses down there, whether you're a general dentist, prosthodontist, periodontist, or what have you. I think this is a great tool we can use to improve the care, quality care of our patients. Oral Health Month, me and my wife, who's a hygienist, every February we go out to a school and we do Oral Health Month, and this is my 6-year-old's teacher. I thought they stopped making this disclosing stuff, but we found some, and the class, they enjoyed it. This is my daughter Ava, dressed up, and this is a class that we spoke to, and the most impressive thing was the gift that I got. The gift that I got is all those students that next week presented me with a card, and they drew me, and they drew what they felt about dentistry. And so that let me know that we're connecting, even at a young age, to these kids, which is very important. So this is my wife. We're reading a Dr. Seuss tooth book to the kids, and they really enjoyed it. So also Dentistry from the Heart is an organization that I also volunteer with. Also went to a mission trip in Tlaxcala, Mexico, which is in the middle of nowhere, where I really saw what really poverty was all about. So we did a lot of surgery and help the kids there as well. So I also found a way to give charity dentistry to puppets. So I'm going to show you guys just a little brief clip, and then we're going to get to the meat of the matter about retreatments and teeth.
Dr. Short!
Yes, what is it, Brianna?
My tooth is hurting. I think I need a root canal.
Well, let's take a look.
I heard that you are an expert at fixing sick teeth.
Well, yes, but...
So you can help me fix my root canal?
Sure. First of all, do you know why you need a root canal?
No.
Well, let me tell you. It's just like taking a bath. Sometimes, if you don't take a bath and clean up really well, you can get dirty. And it's the same thing as brushing your teeth. If you don't brush your teeth well after candy, the tooth gets dirty, and then there's bugs that eat your tooth and cause a tooth to get sick.
Oh no. So how do I keep that from happening to my teeth?
Well, you have to keep them brushed very well, but even still, you still may have to come and see me as a special root canal doctor.
Oh, so do you think I need a root canal?
Well, let's see. Open. Brianna,
teeth.
Oh, yeah. Can I still have a balloon?
Sure.
Oh, yeah.
So, we all can have an impact even on children and even puppets or muppets or whatever you want to call them. So, what are we going to be talking about tonight? We're going to go over the objectives tonight. We're going to discuss some reasons for endodontic failure. We are going to talk about some success rates of retreatment. We're going to talk a little bit about implants as far as success rate and some of those things that go along with that. Retreatment strategies and techniques. So, I'm trying to kind of change the mentality of root canals fail. And because that's so common, that's what patients hear, and that's one of the reasons why they don't want a root canal, because they hear root canals fail. But no one ever addressed the fact that the patient may have failed to heal. And you have to balance both. So Shimon Friedman, who's also an endodontist, he talked about, let's call it post-treatment disease instead of endodontic failure, because sometimes we put a negative connotation on something and people just kind of ride it out, and that's what they think. And I think that's why root canals are the butt end of a lot of jokes, even from commercials all the way to the president made a joke about root canals, and our organization actually called him, wrote a letter, and he kind of apologized about that. So anyway, we want to try to get these things out. Now, what are some things that cause post-treatment disease? Persistent or reintroduced intraradicular microorganisms such as E. faecalis in Canada, extraradicular infection, actinomyces israeli, bacterial plaques. Actinomyces israelis probably take you back to dental school, huh? You guys remember that term, actinomyces israeli? I know perio guys probably talk a lot about that as well. Foreign body reactions, lentil beans, cellulose fibers, and also true cyst. Got a question for you guys. Where do you think a cellulose fiber can come from that can cause a foreign body reaction when you're doing a root canal? Who said that?
Restomyces.
Restomyces? Who said? Paper point. Paper point. Paper point. That's exactly right. Paper point. Oh man, that's great. Did you see my lecture before or something? Good. All right. All right. So I'm going to give you one of my books here. So that's a great answer. Many people don't even know that. So that's excellent. So anyway, yeah, paper point. When you dry a canal and when you stick it in there, and how many people accidentally dry outside the apex? I guess I'm the only one. Okay, we got a couple of honest people in the room. Great. So when you do that, sometimes it depends on your paper points. It's made out of cellulose. Some of these things can get dislodged in the apex, and it can actually cause a foreign body reaction. And you can do the best endo, but the endo won't heal, or they'll develop some type of inflammation there, and sometimes you have to do surgery. And some of this was verified by Sundquist as well. Did you know there's up to 40 million endodontic cases are treated annually? And about 75% of root canals are treated by the general dentist. And about 40%, and I thought this was kind of startling, this number was about 40% of general dentists refer to endodontists. And I would say with the economy and things like it is now, I would probably say it's probably a little lower than that. Now these stats came from the AE survey, which is the American Association of Endodontists in 2010. And these are some success rates. I know it's a very small reading, some success rates of orthograde retreatment from 1956 to 2004. And there's a range anywhere between 40% to 90%. Also, there is studies that talk about which ones heal better. And the ones that usually heal better are the teeth with no lesions. So those usually heal about 15% better than the ones without lesions. So what's the average success rate for endodontics? Orthograde endodontic treatment, in other words, you're doing a root canal from scratch, runs about 90 to 95% overall. Retreatment is a little lower, 80 to 93%. Now, but again, these are averages. And surgery runs to 40 to 78%. It depends on who you're talking to. There's an endodontist that does surgery all the time out of, I'm not going to tell you the school, and he said he has 100% on his surgeries. which, okay, whatever. So that's what he says. So what about endodontists versus general dentist success rates? Somebody tell me, what do you think the average endodontist, you cannot answer this question. I already banned y'all, okay? So everybody else other than endodontists, what do you think the endodontist success rate is in general for root canals? Some numbers. 94%. Anybody else? Want to take a guess? Stan, I guess you're the man. Let's see. 98%. 98%. So what about for general dentists? What do you think it is for general dentists?
88.
88?
75.
70. Who said 75? 75, 88. Give me a few more. 80? Who said 80? 80? 80 in the back? Going once, going twice? You said 80. Okay. All right. The general dentist success rate is about 80 to 90, 89.7%, which is actually still pretty good. Is it actually pretty good? So, and these were verified by Eliezer's group over there in Alabama back in 2004, and it may actually be a little higher because now we have the microscopes, we have different file systems and all these other fun and cool things that we use now. So, do root canals fail or do patients fail to heal? So by show of hands, who says root canals mostly fail? Let's show of hands. If they're going to fail, it's because of the root canal. Go in the back. These guys are sleeping. There was too much chicken, too much tryptophan back here. So what do you think? The root canals, do they fail? Do patients fail to heal? Let me help you out. What would you think your patient would like to hear? Or what would you like to tell your patient to make you look better? I hear some chatter. Somebody? All right, let me help you guys out. All right. If you have any sense, you would say, Miss Jones, the root canal I did was great, but you didn't heal. Is that lying? No? Somebody tell me, why isn't that lying?
Well, because it is a real technical job.
Okay.
So-called technical.
Yes, sir.
What you're doing is cleaning up infection and pushing it inside the canal. And outside, it's really painless.
Now, you guys know he was an endodontist in his former life, right? You guys know that. He's a prosthodontist now. So basically what he's saying is that you clean it out, and you can do the best job cleaning these things out, but guess what? The patients still have to heal. It's still up to their body. So I have to say this, and I do say this amongst some other colleagues who push products and talk about, oh, this is the best file system, or this is the best cleaning solution, and you can get caught up in that. I mean, dentists spend a lot of money on the newest and greatest thing. But they fail to realize that we're not just treating a tooth, we're treating a person. There's an immune system attached to that person. There are certain cells, there are certain genetic defects. So anybody think this looks like somebody probably had a little bottle of scotch maybe a night before here with that post going down out there? So leaky restorations, root fractures, untreated canals, inadequately clean canals, operative errors, and so on and so forth. So when should retreatment be considered? I thought one day I would get away from perio, but perio seemed to track me down everywhere. And we still have to look at the periodontal status. We still have to do probing. We still have to look at attachment. So we still have to take a PA. And I'm very thankful that I had the ability to practice general dentistry before I did endo. So I have a different perspective than perhaps someone who just went straight through school. And it's very critical to know what can be salvaged and what can't. Now, by a show of hands, how many periodontists still know how to do crown lengthening? All right, thank you. At least one in the room, right? So sometimes we have to try to find someone. We do have a patient every now and again. We can do the endo. They need crown lengthening. They don't want an implant. And we do have to sometimes search high and low to find a periodontist that would more than likely do a crown lengthening to try to save the tooth. I know Dr. Static is laughing, but I'm dead serious. We want to look at the strategic value of the tooth, remaining tooth structure, so on and so forth. Because sometimes, just like this car got trapped with this big engine, it ain't worth trying to fix it. You have to look at patients' concerns. You know, especially how tight the economy is. People don't have money just rolling off their toilet stand like that. So you want to look at their expectations, motivation, how motivated are they to try to save the tooth. Let's look at cost. Let's look at how much it's going to cost me to do the endo, to do the build-up, to do the core, do the crown, versus take it out, do an implant, do a bridge. So we want to look at cost. And the main thing is communication. You have to communicate this very well to the patient. The diagnosis is very important. The prognosis is very important. And also the treatment options. We're going to talk a little bit about that. And I tell patients, even though I think that I'm very good at what I do, I can't guarantee this is going to work. I can't. And I tell them those success rates based on evidence-based studies that I've told you guys about before. But if you can save a tooth and the patient, especially a number 9 and 10. No, let's do 8 and 9. I was in a seminar 2 weeks ago in Boston, and I learned something very important about implants. And what I learned was that if you got teeth 8 and 9, the last thing you want to do is extract them and throw 2 implants there. Now, can I get an amen by any periodontist? Okay. And I didn't realize what type of bone change, aesthetic change, I mean, it is amazing. And when we saw that, and there are some periodontists that spoke to us, and prosthodontists that spoke to us, and we saw some of these cases, and some of these cases in an academic environment, it's like, wow. And trying to put implants and trying to do the best crowns. I mean, patients don't really know what to think, and sometimes you really don't know how far that bone is going to go back, or how far the gingiva is going to go back, and all that kind of stuff. So you want to try to save these teeth, and it's priceless. Just as priceless as me taking my daughter to her first daddy-daughter dance last week. Very, very priceless, and I wouldn't have traded for anything in the world. So let's talk about retreatment versus surgery versus extraction and implants. Retreatment, if you can save the tooth, is always the best option. It reduces the need for surgery. It also improves the surgical prognosis if you have to do that. We do some surgeries. Some of the reasons why we do surgeries: calcified canals, procedural errors, large post, root fractures, root anomalies. I usually don't perform many surgeries, maybe about 10 a year. I have some colleagues, they say, hey, Dr. Short, I perform 10 a week. And, you know, hey, beauty's an eye of the beholder. I do a lot of retreatment. I have high success with retreating. Most of my patients do not want surgery. I found in my I just celebrated my 10 years of practice as an endodontist. Most of the time, if the tooth can't be retreated, it's cracked somewhere. I don't like to spend their money or make them spend their money doing a surgery. I always say, you just go ahead and take the tooth out and just get an implant. Now, there are some cases I was like, you know what, surgery may work, but if my endo went well, if the retreatment will look good, and if it's not working, a lot of times it's cracked, whether we can see it or not. And so, extraction and implant is sometimes needed. You can't restore the tooth, guarded periodontal prognosis, the tooth is split, the vertical root fracture, so on and so forth. This is a case that was sent to me from a general dentist about 10 years ago. And it was a tooth number 30, and the endo, I don't know if you guys can see in the back, but to me the endo looks pretty good. What do you guys think? It looks pretty decent, right? Now, I don't know why they put 2 posts in there. I went to the Medical College of Georgia. Well, I don't know the new name, whatever for that school is. I was trained that every root canal treated tooth, you put a post in it. How many of you guys came from that school of thought? Raise your hand. Wow, you guys didn't get... Can you raise them a little higher? All right. How many of you guys were taught you don't use a post unless you have 3 or more walls missing? Got a few. How many people just don't know what the heck is going on? I guess that's the rest of y'all. All right, so let's move on. So I retreated this tooth, and I thought I did a pretty good job. I took it apart, took my time. I even got a little bit of calcium hydroxide out, which is our medicine of choice, used as endodontist. Got it right out to the lesion. I was happy, and look at my result. Now, how does that look to you guys? That looks pretty decent, right? looks pretty decent. So I was like, man, you know, this is going to be great. I followed the patient. 2 years later, sinus tract, we flapped it. Look at this, vertical root fracture. What caused that? Was it the post that caused it? Now, when I did the retreatment, I took the post out of the microscope. I didn't see a crack. That crack could have been external. It didn't probe initially. You know, what caused that? Was it, you know, when we went and did the retreatment, did we take too much dentin out? Was the patient abruxer? Was it a grinder? Those are some things that we may not ever know. But what we do know is that when we flapped in order to try to do a surgery, we saw that, and this tooth was a great candidate to be extracted and an implant. All right? How many of you guys are going to go and see this movie when it comes out? Three Stooges? You got 1 or 2 people? All right. It's going to be a great movie. I love the Three Stooges growing up. So anyway, what do they have to do, the patients, after they, you know, get extracted? Sometimes they don't have to do anything. I didn't say that was the smartest thing, but that is an option, right? They don't have to do anything. You know, you can do a partial. Of course, you can do a denture. You can do a whole bunch of stuff. Bridges, implant supported, prosthesis, all that stuff. How many of you guys, general dentists only, have heard that implants are more successful than root canals? All right, we got a couple of people, 3 people. Why do you think you've heard that? Implants are way more successful than root canals. Who do you think is pushing that agenda? And it's not a Democrat or a Republican. The Tea Party. There you go. It's companies that advertise. We got Dentistry Today. Now, Dentistry Today, I found out by some of my referring doctors, this is their Bible. This is what they live off of. I'm serious. And I'm talking about you guys. You guys probably Pankey graduates, Dawson graduates. You believe in CRNCT or whatever it is, CRNCP. What is it now? Whatever it is. But I look. This is the latest Dentistry Today. There are over 30 different types of implants advertised in this. And I talked to Kumar, and I thought there was a lot. He said there's over 80. 80 different systems. How do you know which system is the best? How do you know which system to avoid? How do you know the long-term effects of the system? What if they stop making the parts? You know? Don't answer that, Kumar. You're ready to answer that, aren't you? That's right. And then they go out of business because of the economy. You guys going to make it, right? They won't, right? So I just kind of dug up a few articles, and this is just one of them in the Journal of Endodontics by Dole in 2006. Restored endodontic treated teeth and single-tooth implants have similar failure rates. Similar failure rates. So we're comparing apples to apples as far as a root canal treated tooth versus an implant. Okay? Are we really comparing apples to apples? Are we really? Let's talk about if we're really comparing apples to apples. You can't really compare success from anything that's man-made versus something that's God-made. You can't compare the two. They're not apples to apples. They're apples to oranges. Something is natural, like a tooth. You're dealing with the attachment apparatus. You're dealing with all those other things versus osseointegration with the implant. Most of the implant research that I've seen that was pretty decent, they talk more about survival than success. Because when you're looking at root canal treated teeth, our success versus survival is a lot more stringent. How many of you guys have had patients that came in with a lower molar, had a lesion on it with no pain? And they asked you guys, how long that's been there? I don't know, 20 years? Is that endodontically treated? Does that mean that is that a failure? Does that mean it's successful? Where do we draw the line? Where do we draw the line? And I'm not asking you to answer that. I'm not saying that I have all the answers, but it's something that we need to think about. Because both have similar, we do understand both have similar failure rates. This was a case that came to see me on tooth number 19, but I was a little concerned about tooth number 20. And I want you guys to let me know if this is successful or you think it's a failure. Stan says a failure. Can somebody else? Raise your hand. Who says a failure? We We go in there. That's great. Great. What's your name, sir? What's your name, sir? John. He is a smart guy because he asked some questions before he came to a conclusion. And a lot of times as dentists, that's what we do. We don't even ask any questions. We just jump to a conclusion. Fail, let's take it out. So, we have a few people that says failure, right? Okay, who says successful? No one says successful? Possible? All right. I retreated number 19, who's having symptoms. Tooth number 20 had treatment over 20 years ago and is still asymptomatic. He refused treatment on number 20. 20 years ago. He told me he had a guy that did it that was, I'm going to tell you who it is. Anyway, I don't consider this as a failure. I don't consider it really as a true success. Okay? But I do consider that it's surviving. This guy said, please do not touch this tooth. I don't have any pain, no mobility. It feels great. Now, we want to be overly critical as a dentist. Say, yeah, looks like I got some recurrent decay. Yeah, I got some darkness around here. This guy's been functioning this 20 years. Let me ask you this. You say, okay, you know what, Mr. John, I know you like this tooth, but I'm just afraid that, you know, if thing is going to give you some problems. You take the tooth out. You do the beautiful implant. The implant fails. How do you think Mr. John, how do you think he's going to feel about you? Okay? And you already answered that in your mind. All right? Don't say it out loud because you may say a curse word. All right. So, implants. Who's the best? Anybody keeping up with the basketball stuff going on? All right? So, Wilkie's the best, right? So, we got Michael Jordan and this other young guy over here, LeBron James. The periodontist. Maybe the oral surgeon. And I'm going to camp out just a little bit. I still don't, it's like, these guys are, in my mind, are equally good. Now, there are some other factors I do consider when I'm deciding to say, hey, you know, I need to see a periodontist or a surgeon. But in their own little group, would like to be a fly on the wall and hear them argue that point. Who's the best? All right? Then the general dentist. A lot of general dentists. How many of you guys do your own implants now? None? We got one or two? Okay. As a general dentist. Okay? Prosthodontist. Whom I'm going to leave you out. I'm talking about the surgery.
Keep me out.
Keep you out. All right. Endodontist. So, these people are marketing products to anybody who really want to buy it. You go to a weekend course, you place implants. If you don't know how to place implants, you're stupid. Basically, that's what I hear. So anybody can do it, but it does depend on case selection. Case selection and experience is very, very important. This patient came to see me from an oral surgeon. Sorry, I'm not clowning on oral surgeons' back, but they came to see me because they had some sensitivity on this premolar here, but they said something felt like they was rubbing against their cheek. And I said, wow, that looks like an implant. She said, yeah. She said, do you think there's something wrong with that? And I said, well, I don't know. You probably want to just go back and talk to the person who did. You asked them. So, implants are great if a natural tooth can't be salvaged. And like I said before, we talk about survivability versus success and failure, and then we're a little closer to comparing the two. So we know we have some implant complications as well as endo. I did talk about some of that stuff. We have some hemorrhage issues, neurosensory problems, mandibular fracture, air emboli. So the list can go on and on. We do have some issues with implants, especially if they're done by, I'll call, no-vice clinicians. You know, so you have the bisphosphonate issue, according to Goodacre and a whole bunch of other prosthodontists and things like that. So let's go into the meter. We're going to show some cases here. So you get a phone call, you say, hey doc, I need some help. I broke off a file in my mother-in-law's canal. What endodontist are you going to use for that? Don't answer it, okay? So here it is, separated file, possible perforation, inadequate obturation, limited access to a crown. This patient was actually sent to me probably about my first week of opening. I had a total of 7 hours I could have worked on one patient, so it really worked out well. So we took care of it. We used the microscope. I have the microscope as a demo up here real quick. Mike Austin was going to kind of help me out a little bit on how to switch from sources. I do want you guys to see the microscope here, if I can actually figure it out how to go here. I don't know why I'm skipping over S video. Anyway, all right, so I do have a microscope stand sitting up, so anybody want to take a look at it. It's just, I don't know, does anybody know how to do the source thing for the projector? Oh, there he is. There he is. This is Mike Austin from Global Surgical, so he came to help me try to figure this thing out. He told me he was going to go fishing, and he's just getting back from fishing just to come back and help me. Is that right, Mike? There you go. All right. Great. Okay, that's great right there. So does anybody know what this is right here?
50 caliber. Civil War bullet. No, it's actually a long bullet.
Wow. You know what? If I didn't believe in not giving two people another prize, I would give you another one. Gee whiz, man, you're good. You know, that's exactly, can you repeat that?
It's a 50 caliber mini ball is basically what we call it.
50 caliber mini ball. Jeez. Bullet. The way I got this was because I volunteered at Good Samaritan. And what happened was, there was a guy, he didn't have any money, but he was a big Civil War guy. And he said, you do this root canal, you know, can you help me out? We helped him out, we did the root canal. He brought me this thing, and I'm like, what is that? And he explained that to me. He said, right up from my office, there was a hill, and I forgot the general name, that was his old fort, right in Smyrna. Do you know that too? Okay, all right. And so he had one of those scanner things, and he found this. And see, he said, but I got something even better to show you. He said, I got this. Does anybody know what that is? And if I told you, do not answer that. I've already told you. Everybody know what that is? That's the same as this. The difference is, have anybody heard the term bite the bullet? Ever heard that before? Well, basically, what happened was, in those days, when they had to amputate, they had to bite on something to keep them from breaking their teeth and to transfer the stress from the pain to something else. So this is the lead bullet with teeth marks in it. You see that? I think this is pretty cool.
Wow.
So I'm actually going to pass this around. Do not steal it. It may be worth a lot of money. I'm still paying off my student loan, so we'll pass it around. So it's pretty cool. So that also goes to show you that it really pays, and you never know. When you work on people, they may not can pay you with money, but they can pay you with other things that can be priceless. So these are some teeth here. As you can see your nice crown prep. So the microscope isn't just for endo. You can use it for all kinds of things. And also, you know, I'm not being paid to sponsor Global. I use Global, and I think that they are good. There are some other microscopes out there that are just as good. I've been using Global now for, I don't know, about 12 years, and it's a workhorse, and it does everything I need it to do. Also here you got some teeth accessed here. We can kind of see if I can go a little bit. Let's see. I don't know if you can see here. You can see the access here. You can see the canals. You can see things that you will not be able to see in the loops. So anyway, I have this here for you guys to kind of play with this as well as we move forward here. So Wilkie, how am I doing on time? Does everybody fall asleep? Am I okay? I got 5 minutes. Goodness gracious. I got 5 minutes. So let me switch this back over, and we're going to do some speeding here. How do you switch this back over, Mike? Is it the same button? Oh, wrong button. Search. All right, so we looked at the microscope. Where do we start? We got to look at this case. Pre-op, post-op, we did a retreatment here, MTA, fixed it up. What kind of tools do you need? We need a whole bunch of stuff. We have some new technology. We use the cone beam. I personally don't have one. I have access to one. I think Rico has a cone beam, and these are great. It gives us more information. We're diagnosing and treating patients as well, especially if you're doing a lot of surgery. The cone beam is great. Ultrasonics and tips. We use chloroforms. We modify some instruments to try to remove certain instruments as well. Got the gates. Restoration, sometimes we have to remove or go through these crowns. We use, do you guys use that zirconium-based crowns? Man, those things are pretty tough to get through, to get off. SS White makes a great Z-burr, and that's the only burr I've used, probably about 10 or 15 different burrs. That's the only burr that I found. It zips those things off and go right through them very well. Removing obstruction, sometimes you need a tank to take some of this stuff out. Post, this looks like something that they probably crucified Jesus on the cross, but sometimes they seem that big on the microscope. Removing gutta percha, rotor instruments, heating, the gutta percha, ultrasonics, so on and so forth. We have to take out silver points. We use a combination of these things. This is a case here, tooth number 19. The general practitioner periodontist wanted to extract an implant, do an implant there. The patient wanted to keep it. You can see the lesion here. We retreated it, calcium hydroxide for 2 weeks, finished the case. Large lesion, we did a recall, 5 years, and the area healed very well. So these cases can be treated successfully. We also have obturators, thermophils. A lot of dentists use thermophils. You have something else coming on the market that's a modified version called Gutta Core. This will be kind of like taking the place of thermophils. I still call it a carrier-based obturators, and I can probably tell you that probably less than 10% of endodontists will use this. So if endodontists aren't using it, I don't encourage general dentists to use it as well. So this is a thermophil retreatment case. This endo looks pretty good, has a lesion. Calcium hydroxide, we brought the patient back, 1 year recall. This is a thermophil case, big lesion. That endo looks pretty good. You see the thermophil here wrapped around there. We take it apart, we pull it out. Do you see any gutta percha on there? No. Okay? So this is kind of like a plastic silver cone or silver point to me. So removing paste, we don't want to use any paste, Sargenti paste and all that, but sometimes we do have these cases, we have to take these pastes out. Tooth number 15, why you want to use a silver point in the distal canal, paste in the palatal, gutta percha in the mesovocal, I don't know. But they did that, we took it out, we cleaned and shaved, we found an MV2 thanks to the microscope. So this is before and after. Found 2 canals. Other considerations after retreatment, we got to consider that you can have flare-ups. A Medrol dose pack, I don't know if you're familiar with that, you need to have that in your armamentarium. Patients have flare-up, they have a lot of pain, or if you even think they are druggies, Medrol dose pack is so good. If they say it doesn't work, they're lying and they want drugs. So just kind of letting you guys know that Medrol dose pack works at least 90-95% of the time. This is a patient came in my office, CEO. He had endodontal number 8. He had surgical enucleation because the area could not heal up. He came to see me. Of course, he has some choices to make. I'm sorry, I'm speeding up because I'm running out of time. So we retreated it. Had sinus tract. We always trace the sinus tracts here. We did a 1-visit retreatment. We use MTA to seal perforations. Can someone tell me some other reasons why we use MTA?
Open apices.
Open apices. Pulp cap. All right, I'm running out of time. So for, I'm so bad with names. Jim, right? Jim, for you asking the first question, I'm going to actually give you a pack of MTA. All right? And I don't know if you know, this stuff is very expensive. This stuff is about $100 a gram. It's like legal cocaine, okay? But don't sniff it, all right? It'll mess you up. So anyway, we retreated the case. Everything went well. The case healed up. The patient was very glad he didn't get an implant here because of some of the same reason. We were able to save it. So MTA, it's our miracle material. It's got a lot of stuff in it. It was made exclusively by Dentistry. It's been available since 1993 by Obturators. Also, Jim, if you don't want the MTA, you can also put it on eBay as well and make you some money. So we used to have the black kind of MTA. We changed to white because it's a lot more aesthetic. Perforations, apical retrofields, apexification, apexogenesis, some of those things that some of you guys mentioned before. We want to keep our teeth as long as we can. This is a case, medically compromised patient with HIV, huge lesions post. Most people would extract this tooth. Patient wanted to keep it. We retreated, we put calcium hydroxide, we finished it up. No, we did not get to the apex like we want. Yes, it looks like we might have transferred the canal or zipped it, but we brought the patient back in a year. Look at his healing. That's, you know, speaks for itself. So hopefully Hawks will win on Friday, hopefully. This is another case. Patient wanted to save the tooth, had a lesion on it. We took the silver post out. I don't know if it was a point or a post. Put calcium hydroxide, we put MTA. Again, we got some nice healing with that as well. I think this is the new area implant. Does anybody know what that is? Tongue ring, right? All right. So we have this case, tooth number 30, furcation issues, no probing. What do you do? Wilkie, what you do on this? You extract that, do an implant? Refer to endodontist. You got to be more careful. Wilkie, you're a genius, man. We got a t-shirt for you. We got an extra small. Can you wear that? No? Okay. So we took it apart and we obturated with gutta-percha. 6-month recall. We brought the patient back and you can see there is healing in the furcation. I am hurrying up and I'm almost done. We didn't have to do perio. I even asked Pinocchio in Disney. He said I wasn't lying. It does heal up with endo. So tooth number 30, a large lesion. What is this stuff out here? Does everybody know what that stuff is?
Sealer.
Sealer. Sealer. Who else? What else do you think it is?
Dical.
Dical. You close. You hot. Come on. Dical. What is Dical? All right. I'm still going to give Jason the tool set because he helped y'all out. So I'm going to give Jason the tool set here. So you can try not to use that when you're retreating any cases because that's a real hammer, mallet, and screwdrivers in there. So anyway, before and after, everything healed. We had some same thing, big lesions, small lesions. If it's endodontically treated or endodontic caused, they still heal. Number 3, sinus tract, overfill. Uh-oh, what do? Do we jump into surgery? No, we are upset that we did overfill it. So let's go and retreat it. I found an MB2. Patient did not want surgery. I brought her back in 6 months and the area healed without surgery. Do I still go in there and do surgery because the gutta-percha is hanging out to the sinus? Do I still go and do surgery based on the way the x-ray looks? Probably not. Why? So last case here, tooth number 30, this patient came in pain. She said she had an endo done and she feels like something is stuck in her jaw. You can look pretty closely. I kind of agree with her. She does have something stuck in her jaw. When we took it apart, we found thermophils in there, overfill, and we also found a separated instrument in there as well. So we did this retreatment for this nice young lady, 1 visit. She was very happy. She was able to save her tooth even without surgery. So it's prudent to give all patients options so that they can make an informed decision, which is practicing good dental ethics. That makes all of us look good. As dentists, we must practice that which is in the best interest for our patients, not in our pockets. And you just ask yourself, what would you want if it was you in the chair? Would you want your natural tooth or would you want an implant? If at all possible, what would you want? Or you can have this. So the choice is always yours. So the natural tooth is God's giving implant. This is a celebrity photographer, Robert Ector. He's worked on all kinds of people. Great to have in my office. I do have a new book. It's out now. Thank you guys for whoever purchased my book already. It's an inspiration book. It doesn't have anything to do with endo, but it has something to do with life. It's a Christian-based book. I have an article coming out next month.